Up next, we have Dr. Eng with the University of Chicago. Dr. Eng is a double board certified surgeon, and he will be sharing some slides today. His specifically is in surgical oncology that focuses on the treatment of cancers in the abdomen, and in particular cancers that have spread to the peritoneum. He specializes in complex cytoreductive surgery and HIPEC for locally advanced and metastatic cancers. So the floor is yours, Dr. Eng. Thanks.
Thanks and good morning, and thank you to the ACPNP for the privilege of presenting today. It's very inspiring to listen to all the talks that have been given so far. These are certainly leaders in our field, and with diseases that are as rare such as this, it's important that we have the enthusiasm and initiative to continue to improve both the clinical care and the research that is associated with it. My talk is a little bit different in that it's a bit of a hodgepodge in terms of talking about novel approaches to high-grade appendix tumors and also some of the research that we're doing here at the University of Chicago. And this is just one bit of the fantastic research that is ongoing. And so I encourage you to stay tuned for the upcoming talks for more updates on research as well. And so this is an outline of the talk. We will first talk about challenges of managing high-grade tumors, followed by laparoscopic HIPEC, and then iterative HIPEC, which is multiple HIPECs over a certain period of time, and then the ongoing research that we're doing here. And so, I think high-grade tumors are one subset of appendix cancers that we're evolving in our understanding of it. And just to give a perspective, there are many different types of appendix tumors, as many of you know, and this is not even a comprehensive list of these tumors, but as you can see, these reflect the wide variety of appendix tumors that exist, and we're going to focus on the high-grade tumors, or the tumors that are more rapidly dividing and the faster growing. So these are typically the poorly differentiated appendiceal adenocarcinoma, or the typical appendix cancers, as well as the adenocarcinoma X goblet cell carcinoid tumors, which have signaling cells or are also poorly differentiated, which are markers of aggressiveness as well. And so we will be focusing on those subsets of patients. This is imaging from a recent paper that we published, which demonstrates laparoscopically some of the tumors that you see in the abdominal cavity from high-grade disease. And you can see these whitish plaques on some of these tumors, which are the disease that's spread in the abdominal cavity. We liken the peritoneum to sort of the paint on the walls of a house, and sort of that the tumors will latch onto this paint on the walls of your abdominal cavity. And in many situations, we are able to take that paint off, but in a lot of situations, the tumors are so stuck that we have to actually take out organs and do visceral resections as part of our big cytoreductive surgeries, which add to the potential morbidity and complications of surgeries which were outlined by Dr. Levine's talk. And so, I think that those underscore the challenges of these high-grade tumors in that they are aggressive, they spread fast, and in many situations, there is a high burden of disease that's found when the abdominal cavity is entered. And not only that, even with chemotherapy, there is potential for recurrence after surgery, which is many times sooner than the low-grade tumors that take a longer time to come back. And as a result of all of this, with a high burden of disease, aggressiveness, and recurrences, these tumors do impact quality of life and symptoms dramatically in many instances. And so, we've talked about this in the peritoneal cancer index, and how do we know that something is high burden? Well, we use the PCI score to quantify the tumor based on location and size. And, despite that this being developed in the 1990s, this is still something today that we use to help guide our recommendations in terms of management and care for these complex malignancies. And so Dr. Taraga touched upon the Chicago Consensus Guidelines that we recently published. And I think, I'm not going to spend too much time on it, but, and again, you will get this information in a handout, but this underscores the fact that appendix cancers need to be managed in a multidisciplinary setting at centers that do this a lot. And because an algorithm like this requires the collaboration of not only surgeons but medical oncologists, sometimes even radiation oncologists, pathologists, radiologists, to make a consensus agreement as to what is the best plan of care for a patient with this rare disease and with this complexity. And so I think going back to the challenges of high-grade tumors, which sort of add to the whole complexity of this management process, is that, when patients present with a high burden of disease, there are some times where it is just unresectable, where even those of us who do this all the time go in and say, there is too much disease to take out, or if we were to, you always have to balance this risk of how much you take out versus how many organs have to be resected versus quality of life. And I typically give the example that if we have to do this huge surgery and we know the recurrence is going to be very quick, well, is it really worth it to put somebody through all of that, put them in the hospital for a long time, have increased pain, impacting quality of life, when the disease will simply recur in short order? And so, these are particularly difficult situations that we have to learn how to navigate and better understand in that kind of a situation. And so, something that we do here at the University of Chicago quite frequently is laparoscopic HIPEC, or minimally invasive HIPEC, in which we put in a bunch of 5 to 8 millimeter trocars, and laparoscopically look at the abdomen, quantify the amount of disease that's in the abdomen, and perform the HIPEC this way. And so this is just an example of a typical setup in which we have our inflow and outflow from the HIPEC portion going through these cannulas in this minimally invasive fashion. And there are definitely advantages to this technique. They involve 4 to 5 small incisions. Patients can be discharged even potentially the same day, or usually they stay overnight. There's minimal pain. I've had patients who resume work within a day or two afterwards. And it also allows for early resumption of chemotherapy, because again, chemotherapy attacks your good cells in addition to your tumor cells. And so it's always navigating this balance of surgery and chemotherapy. And so, if you just take a bird's eye view, the bigger the surgery, the bigger time off of chemotherapy. And so you always have to strike that balance with these aggressive tumors about how do surgery and chemotherapy, work within this algorithm of giving you the best chance of having the best outcome from your aggressive cancer that's advanced. And so, we use these principles of laparoscopic HIPEC here in not just appendix cancer, and this is just an example of a clinical trial that I have open in advanced stomach cancer, where we are actually applying the same technique to see if we could potentially control the disease better that way, and also get a better understanding of the molecular changes and immunologic changes that happen with the tumors with this technique as well. And so, given that you can do laparoscopic HIPEC and have minimal morbidity from it, and then patients recover well, we've sort of extrapolated this to high-grade appendix cancers that are unresectable, and have looked at results of doing this technique over a temporal fashion multiple times. And so this is the iterative HIPEC, or in our practice, HIPEC every 6 weeks for unresectable disease. And we looked at our outcomes, and recently published this in Annals of Surgical Oncology several months ago. And we looked at our outcomes compared to patients who underwent chemotherapy alone versus patients who underwent the cytoreduction and HIPEC that we traditionally talk about. And so we performed 18 procedures during this time period. I just want to draw your attention to the fact that almost 80% of these were done laparoscopically, and none of these patients had any complications. And so, this can certainly be done with no complications. Our length of hospital stay was on average 1 day. And these are sort of before and after photos. That left-sided ABC diagram is the pre, and then the right side reflects the second look after one iterative HIPEC. And you can see, even just from looking at it, that the burden of disease is reduced from one time point to another. So we are seeing reductions in PCI score and durable survival with this technique, again, with minimal morbidity, minimal pain, and minimal impact to quality of life, and earlier resumption of chemotherapy. And so the median PCI in this cohort was almost maximum. It was 32.5, and we found that our survival was better compared to patients who received chemotherapy alone, and it was actually similar compared to patients who underwent the big cytoreduction and HIPEC. In fact, the number was the survival was greater, but just not statistically significant enough, probably because our numbers weren't as robust. But we are continuing to do this here. And as we continue to build our series of patients, we will have a better and better understanding of how this technique and how this clinical practice can work into the algorithms and helping not only your outcomes, but your quality of life, which is equally important. And so just a little bit at the end of ongoing research, and these are just some studies that have been published in the last year and a half, looking at, again, reflecting what Dr. Levine talked about, which is that the appendix cancers, now that we've looked at them genetically, that they are different than colon cancers. And, again, I think because this is an ongoing, period of research, and this is relatively new, this has opened up opportunities for us to further understand, now that we know the molecular composition of these tumors is different, how can we work on improving the systemic therapies or other therapies that are available to you to help manage these tumors and control them better, akin to personalized medicine that cancer care is evolving into. And so this is, again, another study which has looked at the different mutations that exist within different kinds of appendix cancers, just looking at the profiles of these tumors. And so what we focus on here at the University of Chicago is looking at the fact that peritoneal tumors, they are in different areas of the abdominal cavity. And so, should we assume that all these tumors are the same? Because in a lot of times you see tumors in certain areas more often than others, for example, in the right diaphragm. But so what makes them go there first? Are they necessarily the same as the ones in the left diaphragm or the pelvis? Can we get a sense of, maybe do we know where tumors may go first? Because then that may influence how we think about things. And so, I think looking at the question of are all peritoneal tumors the same is crucial to our understanding of peritoneal metastases. And then I think there's a lot of research on HIPEC in terms of, which drug is better, is mitomycin or oxaliplatin better? Are there, in terms of affecting different aspects of the patient's survival? But what if we use HIPEC as a tool to actually change the molecular composition of tumors? Because if that is the case, then can we make an argument that perhaps we can use HIPEC to maybe potentially even down the line make patients eligible for treatments that they aren't eligible for now? And so I think the consequences of this are huge in terms of, if we can actually figure these things out, then we can influence what we can do next. And so, I was very fortunate that the ACMP was generous enough to award their 2019 grant to me to answer these very questions that I'm asking in terms of understanding the genetic landscape of these peritoneal metastases and the effects that HIPEC has on them. And so this is ongoing research that we are doing now, and these are things that we are currently investigating. But I will say that this is just a little bit of unpublished data, not from appendix cancers, but this is from another disease that spreads in the abdominal cavity, which is peritoneal mesothelioma. And we actually looked at immune expression of tumors over time with utilization of HIPEC. And we actually found, and I know these graphs are full of numbers and colors, but we actually found that in a subset of these patients with HIPEC, we could actually change the immune expression of these tumors, potentially with HIPEC. And so that speaks to potentially using immunotherapy at certain time points that may be more beneficial than others. And I think using this data to help guide what we do in other types of cancers may be really beneficial in the long term. So I'd like to, again, thank the ACPNP, but in summary, management of high-grade appendix cancers remains a challenge. Laparoscopic and iterative HIPEC are associated with promising outcomes, and the future research that we're doing will help us better understand the biology and therefore the treatments that are available to you to manage this complicated disease process. You're welcome to contact me if you have any questions. Thank you very much for your time.